the session, sir. You can go ahead.
Good evening. On behalf of our Indian Academy of Cerebral Palsy, Cerebral Palsy Executive Board and Board of Directors, welcome all of you to the wonderful webinar on management of dystonia in cerebral palsy. Our hearty welcome to distinguished speaker Dr. Bhooma Aravamuthan, Assistant Professor of Neurology, Neuroscientist, and Pediatric Movement Disorder Specialist in the Cerebral Palsy Center at Washington University. Welcome, madam. And our hearty welcome to moderator for this webinar, Dr. Shilpa Kulkarni, Additional Professor and HOD Division of Neurosciences, Wadia Hospitals, Mumbai. I thank Dr. Shilpa Kulkarni, madam, for giving consent within a short notice. As Dr. Purohit was traveling to California, we requested Dr. Shilpa, madam, to moderate. She was kind enough to give a consent in short notice. Now, I will give a brief introduction to Indian Academy of Cerebral Palsy. It's a long journey. Since 2004, we established Indian Academy of Cerebral Palsy in 2004 in Hyderabad. The Indian Academy of Cerebral Palsy is a reputed academic body in the country, having highly respected professionals as its members, providing an excellent forum for the academicians and rehabilitation professionals to put forth their wisdom and to enrich their knowledge for better delivery of education, patient care, and sensitization of civil society at large. The Academy has risen to glorious heights ever since its inception, and same as also acknowledged by the international professionals. All of our teaching programs that will provide a great opportunity for fruitful deliberations and enrich the knowledge of young professionals of the field and provide interaction with one another and experts in this field to improve the status and quality of services in empowering the persons with the cerebral palsy of the country as a whole. We all are in this webinar because there is a new knowledge to be gained, and that knowledge to be used by all of us for rendering quality services for welfare of the families and persons with the cerebral palsy. Here I would like to just quote a Sanskrit, Anabhadro Kratapo Yantu Vishwataha, that is in English, let noble thoughts come to us from all sides. With this, I also welcome parents of Dr. Aravamuthan, Dr. Bhooma Aravamuthan, to attend this, who are attending this webinar. Once again, I welcome all of you to this excellent webinar. With this, I request Dr. Asha Chetnis to introduce our moderator, Dr. Shilpa Kulkarni, to take this teaching session forward. Thank you. Dr. Asha?
So I don't believe she is here.
She is there, I think.
Asha ma'am, are you there? I don't see her, sir. She was longing backing. We are live on Facebook, sir.
Achha. So, Doctor, now on behalf of Dr. Asha Chetnis, I think she is trying to stream this webinar on Facebook. She logged out and may log in again. I'm sorry. Dr. Shilpa Kulkarni, she is an additional professor and HOD, Division of Neurosciences, by Wadia Hospital for Children, Leelavati Hospital also. Has a numerous publications and book chapters to her credit in national and international books and journals, received national and international awards, and she is specialized in movement disorders, epilepsy, and in cerebral palsy. I welcome Dr. Shilpa Kulkarni, madam, to moderate this session and take the session forward. It is yours, madam.
Thank you very much for a good introduction. A very good evening to all of you and good morning to Dr. Bhooma and Dr. Purohit. First, I would like to thank IICP for giving me this opportunity to moderate this session. IICP from its inception has been working towards the empowerment of individuals with cerebral palsy. It plays a major role in the continuous education of all the stakeholders who are actively involved in the management of patients of cerebral palsy. And as a part of CP Day celebration, IICP has arranged these educational webinars, which are going to tell us about management of dystonia in cerebral palsy. We all know that cerebral palsy is a dynamic disorder. It's a disorder of movement and posture. It is complicated by a variety of movement disorders, which make it very interesting and challenging for management of these patients. So today we have with us a distinguished speaker, Dr. Bhooma Aravamuthan. Dr. Bhooma Aravamuthan is an assistant professor of Pediatric Movement Disorder Specialist and Neuroscientist in the Division of Pediatric Neurology at the Washington University School of Medicine. She is also a research director of the Cerebral Palsy Center at St. Louis Children's Hospital. She completed her research doctorate at the University of Oxford in England and her pediatric residency at Washington University in St. Louis. Her child neurology and movement disorder fellowships were completed at Boston's Children's Hospital and Mass General Hospital before returning to Washington University as a faculty. She also co-leads the scientific program committees for two US national organizations, the Child Neurology Society and the American Academy of Cerebral Palsy and Developmental Medicine. Her other US national leadership roles include presiding over the Cerebral Palsy Research Network committees on dystonia research and dystonia quality improvement. Her translational research on dystonia pathophysiology following neonatal brain injury is funded by the National Institute of Neurological Disorder and Stroke. She has many publications in this interesting subject in international journals. Her research awards most recently include the 2022 American Academy of Neurology John Stock Movement Disorder Research Award and the 2022 Child Neurology Society Philip Dodge Young Investigator Award. The most important, she's married and a mom to 3 children and taking care of 3 children, twin, a 4-year-old boys and 2-year-old girl. So I welcome Dr. Bhooma Aravamuthan to give this talk and tell us more about your research about in this dystonia in cerebral palsy. Dr. Bhooma.
Thank you very much. I appreciate the introduction. Let me start sharing my screen. And let me know if there's any trouble with seeing it. I think it should be okay. I'll be talking about dystonia and cerebral palsy, which is my professional love. It is a topic that I'm very passionate about, and I'm honored to be speaking with this group, this distinguished group of people about it today. These are my disclosures. There are none relevant to this talk. I want to be specific that I will be talking about dystonia in cerebral palsy. Most of the talks I heard, especially during training on dystonia, focused on rare dystonia etiologies, genetic etiologies, progressive etiologies of dystonia, which exist and can be debilitating and are important to focus on. But I just want to be clear that dystonia and cerebral palsy is by far the most common cause of dystonia in childhood. In America, it's becoming the most common cause of dystonia in adulthood. So thinking about dystonia specifically in the context of cerebral palsy is an imperative for us. It's important for us to shift the conversation internationally to thinking about dystonia maybe primarily or majority in the context of cerebral palsy. So I'm so happy to be talking about dystonia to the IACP today. First, I'll spend the beginning of the talk talking about what dystonia is and how to diagnose it, because you can't manage dystonia without diagnosing it appropriately. I tend to think of dystonia as one of 3 forms of hypertonia, so of high tone, This is not necessarily how everyone views it. Some people see dystonia as a separate movement disorder, separate from these forms of high tone. But I'll talk to you about it in this context, because I think in the context of cerebral palsy, it's important to think about it this way. The three typical forms of high tone are spasticity, dystonia, and rigidity. Rigidity is very rare to see in children, and this is with varying speeds of stretch at a joint. You have a constant resistance to that movement. So there's no variability in the resistance to your speed of stretch at a certain joint. That type of rigidity is almost pathognomonic when seen in very young children and infants for neurotransmitter disorders. And it is almost never seen in the context of cerebral palsy. So if we're talking about rigidity, we're really talking about a different group of movement disorders, a different group of conditions. I'm happy to talk about that in the Q&A. But what I really want to focus on is spasticity and dystonia. These are the most common types of tone that we see in people with cerebral palsy. The basic differentiation is here. So with spasticity, to some degree, it is present all the time. So people that have a spasticity predominant phenotype, spasticity is the main type of tone they have. It will be present throughout the day. It may get a little bit worse when they're sick. It may go down a little bit when they're asleep. But overall, if someone says that, oh, there's a lot of spasticity in the adductors of the legs, they scissor a lot when we're trying to change their diaper, and then when they sleep, they get a little bit looser, but those legs are still crossed, that sort of tone is spasticity. It's also not triggered by voluntary movement, so that's an important differentiator. Dystonia is not that way. So dystonia is by definition variable, tends to be absent during sleep. So one of the main manifestations of this that we see in clinic is parents will say, well, it's very difficult to change their diaper. They're always crossing their legs. They're really tight. But then when they're asleep, they sleep with their legs open. They sleep frog-legged. It's very easy to move their legs when they're asleep. And that type of tone pattern, that variability of tone pattern is classic for dystonia. By definition, dystonia is also triggered by voluntary movement. So the way a person with CP described it to me is every time I try to move, a different part of my body moves out of my control. And that's such a beautiful description of dystonia, because inherently you can see the degree of functional limitation that's associated with it. If every time you try to move, a part of your body moves out of your control, that is dystonia, and it is inherently functionally limiting by definition. These are the consensus definitions that have been established internationally for dystonia etiologies across the board. That's this Albanese paper from 2007. And then in a United States consensus group, and that's this Terry Sanger paper from 2003. So they note sustained or intermittent muscle contractions initiated or worsened by voluntary action associated with overflow muscle activation. That's this concept of when I move one part of my body, a different part of my body moves out of my control. And then the aspect of this that was added by, that was emphasized by Terry Sanger and his colleagues in their movement work group was that the magnitude varies with arousal. And I talked about sleep, so that dystonia tends to go away during sleep, but it's also heightened with stress, it's heightened with illness, it can be heightened with excitement or happiness. So looking for those mood-based triggers for dystonia can be helpful for diagnosis, and as I'll talk about later on, also helpful for treatment. This is the surveillance of cerebral palsy in Europe, a cerebral palsy classification system, and many of us are familiar with this. This has been a long-standing classification system now for over 20 years, mainly deciding if the predominant form of tone a person with cerebral palsy has is associated with dystonia or not. That's really the initial sort of differentiating factor. Is the tone persistent or is it varying? And once you help make those distinctions, the classical teaching is that 85% of people with cerebral palsy tend to have spasticity predominant or spastic CP, and 15% tend to have dystonia or dyskinetic predominant or dystonic CP. What we all know is that this is not really a clean line, is it? That people with spasticity also tend to have a lot of dystonia, even if spasticity is the main component. And what we're being better, I think, about verbalizing now is that even if spasticity is the most obvious form of tone that you might have, that dystonia, even if it's not the most obvious form of tone, that dystonia may actually be the most functionally limiting form of tone that you have. And focusing on all of the types of tone you have, not just the predominant type of tone, and especially what is most functionally limiting for the mobility goals that a person might have is important. So I eschew this classification a little bit. I tend to think of the motor phenotypes present in any person as happening all together. I rarely think of someone as having spastic CP. I think of someone as having CP and spasticity in these limbs, dystonia in these limbs, and this is how this tone affects their function. And that's how I document in my notes as well. And I think thinking about a person in that whole way, as opposed to these boxes, these classification boxes, can be valuable. In work that also came out around this time, we learned that dystonia is very common in cerebral palsy. And in particular, that it is very common in the legs. So this was a study using a tool called the hypertonia assessment tool that I'll talk about later, looking at people with CP and spasticity and looking to see how many of them had dystonia. So looking at these Venn diagram circles, people with spasticity, people with dystonia, and people with normal tone in those limbs. This is looking at across a population of people with CP. This is the left arm, the right arm, the left leg, and the right leg. And what you can see is there's a lot of overlap in how many people have spasticity and dystonia in the arms, for sure. But there is a near complete overlap in the legs. So what we know is that for people with CP in their legs, about 70 to 80% of people with CP will have coexisting spasticity and dystonia. And I think for all of us, it may be more obvious to see dystonia in the arm. Those positions are very familiar to us. But I would encourage everybody to look for dystonia, especially in the legs, and particularly during walking studies where it can be walking videos where you might focus on the manifestations of spasticity that you pick up on your confrontational exam. But really in those videos, you can see these subtle manifestations of dystonia. And it may be that the dystonia is what's most functionally limiting, or at least in part functionally limiting for that person's gait. So, based on studies like this and research that people have since done,
Can you please mute the?
I just did. I'm watching. Don't worry. Go ahead. I just mute.
Thank you. Sorry about that. As I was saying, we're focusing more and more on looking at dystonia in the legs because it is the legs where dystonia is most common in people with CP, which is not what we may think. I'm going to show you some examples of classic dystonic positioning. So these are movements to keep in your mind, but I have here proceed with caution because you cannot diagnose dystonia from a static picture. Dystonia is variable. So looking for that variability is critical. But these are some of the positions that we can see when we see that overflow activation. This is in work again from Terry Sanger's group. They looked at a group of people with CP and saw which positions that were most commonly present associated with dystonia. We see this internal rotation, backward extension, wrist flexion movement very commonly for arm dystonia. This foot adduction, I'll talk about a little later as well. We've started to quantify that as a metric of dystonia severity. And you see that very commonly with overflow dystonia in the legs, the foot moving in. Here you also see the beginnings in this first picture of that toe going up, the striatal toe. And you'll see that here. It's important to differentiate this from a tonically upgoing toe, meaning a toe that's a sign of hyperreflexia or upper motor neuron injury. A striatal toe is almost always pathognomonic for dystonia, tends to occur simultaneous with some other dystonic positioning, and should be elicited with other triggers like voluntary movement, heightened excitement, that sort of thing. It can be difficult to differentiate, but I will say it is rare for a striatal toe to appear in isolation outside of the context of another dystonic position. So look for neighborhood signs there. Opisthotonus, this is also a very common dystonic position. A word of caution here, it's I used to get several referrals for nocturnal opisthotonus, and it ended up being back arching in the setting of reflux. And this can be difficult to differentiate because discomfort from reflux can trigger dystonia. So it can all go together. So thinking about the context in which this opistotonic posture is happening can be useful to differentiate it from other causes of this back arching, but we commonly see it in children with generalized dystonia. So keeping this in mind is a common posture. I want to be explicit that I've talked about, all of these definitions for dystonia, and this is what the positioning looks like, and it's variable, so everybody should be able to diagnose it. And I want to be clear that it is difficult to diagnose, and even for people who are movement disorders experts, there is some degree of uncertainty. So this was actually the three of us, Dr. Tony Pearson, Dr. Keisuke Ueda, and I, and we're all movement disorders trained pediatric neurologists who specialize in cerebral palsy. And when we looked at videos independently and then together, we rated them as either there being dystonia present or absent in the legs before we looked at the videos. And then we got together and discussed as a group. And even among us, and we had gone through fellowship training and had been on faculty for a few years, and this is what we specialize in, with group discussion, and these are these lighter colored tones here, we flip-flopped what we thought before we ended up talking. So we stuck with our initial perception as no, somewhere between, out of 40 videos, 15 to 20 videos. We stuck with our initial perception of yes, in about the same sort of proportion, 15 videos. But for about 8 to 10 videos, we swapped after having discussion. And this is to say that it is valuable to think about dystonia not just in one context and not just as one person. This is something that's valuable to think about as a group. Even after this group discussion, though, of just one video of a person with CP, there was, for 6 of those videos, so about 15% of those videos, we could not reach consensus when looking at one snippet. And this is to say that dystonia can't be diagnosed at one time point. So the first time you might meet someone, you may not notice in the clinic that their dystonia is obvious, or they may be dystonic the whole time due to the stress of being in the clinic visit. And so you may not see the variability of their tone. So repeat assessments are really important. If you see someone the first visit and you say they don't have dystonia, please don't let that label stay with them every single visit. Please assess them fresh for dystonia every visit. Because dystonia is variable, you cannot assess it at a single time point. You have to keep assessing for it. You have to stay vigilant for it. This is a snapshot of the hypertonia assessment tool, which is, I think, the best tool that we currently have to systematically differentiate between different types of tone in children. And it's interesting. I don't know how commonly it is used in your practices. I will say that there's a specialty specific divide in how it is used in my personal experience in the United States, where neurologists tend to use this very little, and developmental pediatricians and physiatrists, physical medicine and rehabilitation specialists who see people with CP use it much more commonly. I point this out because it gives a specific rubric for looking at dystonia in particular: increased involuntary movements and postures of the designated limb with tactile stimulus of a different body part. So if you're stretching a leg and the arm twists, an example of dystonia, or when you try to move one body part, a different body part moves. And that's very similar to the quote from the person with CP that I was talking about earlier. So these can be very sensitive and specific indicators of dystonia. But the problem here is that in the clinic room, when you're trying to do these maneuvers, this overflow, this evidence of overflow can be very subtle. So you really have to keep an eye on it, and you have to do these maneuvers with the express purpose of not looking at the stimulated limb. So for example, in the clinic, if I have someone do a hand open close task, I'm looking for speed of movement in this hand, but one of the primary reasons I do it is to look at this hand, the hand that is not moving, to look for subtle signs of overflow that may be suggestive of dystonia, and to also look at the legs during that hand open close task to look for subtle signs of dystonia. It's those sorts of maneuvers and looking at the not moving hand that'll let you pick up on subtle indications of dystonia that you may have otherwise missed. This is in our center, and I again want to be humble about this to say that dystonia is hard to diagnose and is often underdiagnosed. This is in a group of children who had neonatal hypoxic ischemic encephalopathy, who underwent therapeutic hyperthermia, and were thus at very close monitoring after they were discharged from our neonatal intensive care unit after neonatal hypothermia, because we wanted to make sure that we wanted to track their development. And even in this closely followed population by a group of neonatal neurologists and other neurologists specializing in cerebral palsy, only 24% of this population had their tone types documented by the time they were 5. So to me, this was shocking. It's indicative of maybe not understanding the value of documenting tone type. And we know that identifying dystonia early can be an important treatment guidance mechanism. For example, if you're thinking about a selective dorsal rhizotomy, a neurosurgical procedure to address spasticity in a young child, dystonia may be a relative contraindication for that. So identifying dystonia early is critical to thinking about not just the pharmacologic treatments you might pursue, but the surgical treatments you might pursue. So this is something, again, that we should be vigilant about from a young age and vigilant about at every visit. We established a community-driven research agenda for dystonia and CP together with the Cerebral Palsy Research Network, directly asking people with CP and their caregivers about what they would prioritize we work on. High on this list was improving diagnosis and severity assessments. So I'll talk a little bit about our work there. We wanted to take what we thought of as gold standard consensus. So a group of experts discussing a video and saying that we thought this was dystonia, we thought this was not dystonia, and trying to figure out how to generalize that to people who didn't have access to that group consensus. So we had a group of 3 movement disorders physicians look at 116 videos of people with CP as they walked towards the camera. All of these people had documented spasticity, and we felt this was very important because we wanted to make sure that we were differentiating dystonia from spasticity in these videos. So this isn't just people who were typically developing gait compared to people with dystonia. This was people with spasticity and no dystonia, and people with spasticity and dystonia, because we wanted to make sure we were providing information that was valuable in the clinic. And then we had experts rate dystonia severity on a 10-point scale called the Global Dystonia Severity Rating Scale. 0 is no dystonia, 10 is severe dystonia. And we only looked at dystonia in the lower extremities, in the legs in these videos. So here are some example videos. And as they play, I'll have you think about who in these videos might have dystonia. This might be a bit of a clear-cut designation. But the person on the left who has mild gastrocnemius spasticity did not have any dystonia, and the person on the right does have dystonia. And you can see by his gait pattern the degree of variability with his steps cycle to cycle. When we asked experts to identify why they said that this person did or did not have dystonia, they noted consistency when someone did not have dystonia, so very regular, uninterrupted gait. And they noted variability in the gait in the presence of dystonia, intermittent variable scissoring of both legs. So this comment of adduction, the legs cross in variably. And then they also noted that this variation they felt would limit function. The more variable the gait, the more likely you are to have functional limitation. If we quantify what it is that the experts said when they were identifying dystonia severity, the darker the bar here, the more severe the dystonia. The more experts said the gait was variable, the more likely they were to rate dystonia severe, and vice versa for saying consistent gait. with regards to adduction amplitude, if they said the amplitude of adduction was small, that scissoring, that variable scissoring, the variable foot turning in, that positioning that we talked about earlier, if they said it was small, they were more likely to rate that dystonia as mild. If they said that amplitude was large, they were more likely to rate that dystonia as severe. So we took these statements and looked to see which of the current scales actually reflected these phenomenon that experts used to actually grade dystonia. And these are the validated scales we have to rate dystonia in people with CP. And you see that amplitude is on there. So that adduction amplitude that can be rated is in one scale, but this concept of variability is not. And it is something, the degree of variability that experts tended to use to rate dystonia severity. So thinking about that in your patients may also be valuable. How variable is their gait cycle to cycle? And can we, is that a sign of dystonia? And are the treatments we're using decreasing gait variability? Not necessarily just increasing excursion or increasing speed, but it's that variability sometimes that makes you more prone to fall, the inability to predict what might happen with the next step. So thinking about that can be functionally valuable. We then looked at kinematic analogs of this. So we tried to quantify these different features in these videos. And we used machine learning techniques. So we took those features and used machine learning techniques to quantify these features in these videos. And these are an example of the metrics. We looked at the angle of the feet, inter-knee distance, inter-ankle distance, inter-toe distance. And if we look at those metrics across the board, we saw that there were certain metrics that appeared to be most predictive or most likely to be associated with dystonia. So this blue group is people with dystonia, the gray group is people without. And you see that the maximum amplitude of adduction of the foot turning in or of the knees coming together yielded significant separation between these groups. We say the same thing here with inter-ankle distance variability. So how variable was it that the ankles came together during gait? And then when we plot that across expert rating scale, so the higher scores being more severe dystonia, there were two variables in particular corresponding to adduction variability and adduction amplitude that tracked with dystonia severity. So this is just a reminder that in the legs during gait to look for these features, adduction amplitude. So how much do the legs cross? And do they variably cross? Do the feet variably cross? That could be signs of functionally limiting dystonia in these children. We repeated this study instead of during gait in people while seated to make sure that we were addressing the needs of as broad of a population as possible of people with CP. These are the hand open close maneuvers I was talking about earlier. And as this young lady opens and closes this hand, you'll see the dystonia extend to her legs. And I'll see if I can play this video again, because that's she provides really an excellent depiction of it. You see in that first maneuver, the feet are staying stable, but then as she starts trying to move her more affected hand, you see that the legs cross in, the feet cross in. Here's an example of something more subtle, where when she's moving her hand open, close slowly, you don't see anything. But then when she starts moving it fast, you see the legs come in. And you can see the same thing on the other side. Slowly, you don't see the legs come in. Faster, you see the ankles come in. Really, that subtle sort of movement of the ankles in. So again, an imperative for us to be looking at other parts of the body when we're having people do those voluntary movement tasks. This is an example of a child without dystonia in the legs, but what you do see is mirror movement, and experts were very quick to differentiate between mirror movements here. So you see she's asking him to just move one hand, and I have his face blurred for his own privacy, but he's saying he can't, that the other hand moves at the same time. And that sort of immediate translation, that fluid brisk mirror movement between contralateral extremities, that is not dystonia. That is a different form of overflow that is associated typically with upper motor neuron pathways and not with the sustained positioning that we tend to think of as dystonic. So it's important to differentiate between those two as well. We looked at these same metrics that I described before in these seated tasks. And what we really see here is these measures of variability of the foot coming in, of the legs crossing in, that yield the greatest separation between people with dystonia and without dystonia. There is separation on the amplitude side as well, but it's really these measures of adduction variability that tell us the most about who might have dystonia and who might not. And you can see even cutoff values here that would yield high specificity for someone with dystonia. So we're using this, we're working on this to try and develop metrics for assisting with dystonia diagnosis and severity assessment. Something that I talked about earlier, it's wonderful to look at all of this on exam, and for you as the physician or as the physiotherapist or as the medical provider to try and assess dystonia serially. But we have to be aware of how much expertise caregivers and people with cerebral palsy have themselves. They're with themselves 24 hours a day. So when you're trying to assess something variable, history can be really important. And what we found in a group of about 100 people with cerebral palsy is that when we ask them these two questions, when you try to move one part of your body, does another part of your body move out of your control? And during activities where someone handles one part of your body, does a different part of your body move out of your control? So the examples we gave were for physical therapy. When someone's stretching your leg, does your arm move out of control, or does a different part of your body move out of your control? And when we asked people this, if they said yes to both of these questions, 92% of those people had dystonia. And that finding was 97% specific for dystonia. So this is critical, because if you think about the expertise that people with CP have about their own motor phenotype and how that can guide treatment, asking people just these two questions can give you a really good idea of whether they have dystonia or not. And this is work that we're working on publishing. We're very excited about it because at the end of the day, it's screening tools like this that may make us best able to diagnose dystonia. So now that I've talked a lot about dystonia diagnosis, and I focused on that intentionally because part of our goal to treat dystonia should be to diagnose it in everybody that has it. I'll talk now about treatment. We know dystonia is very hard to treat, and there is an existing care pathway through American Academy of Cerebral Palsy and Developmental Medicine that's free to access. If you just Google AACPDM care pathway, it'll give you the current care pathway. I'll tell you that care pathway is in active revision, and there will hopefully be a new care pathway released soon based on this systematic review published by Darcy Failings and her colleagues Emma Bond and Darcy Failings out of Toronto. And they looked at the evidence available for different pharmacologic, injectable, and surgical treatments for cerebral palsy. Some of this aggregate data is honestly shocking. There is no dedicated data looking at baclofen, benzodiazepines, or gabapentin for dystonia and cerebral palsy. There is one large-scale study published by Jean-Pierre Lin and colleagues out of London looking at gabapentin, high-dose gabapentin, 18 milligrams per kilogram per day and above for dystonia across the board, that was found to be effective, particularly for dystonia that was pain-related. But specifically in CP, those studies are lacking. So shocking, because I think many of us use these medications for dystonia. Clonidine, which I think is often underutilized for dystonia, has some of the best data to support it for the use of treatment of dystonia and CP. And trihexyphenidyl and levodopa, which we tend to think of as mainstays for treatment of dystonia, had little to no effect for dystonia and cerebral palsy. And in particular, trihexyphenidyl not only had little to no effect across multiple studies, including in a randomized study, it may, as we know, it has a high risk of adverse side effects. So in my practice, I no longer use trihexyphenidyl as a first-line treatment for dystonia. Now, we all have stories of a person with dystonia associated with their CP who did respond to trihexyphenidyl. So I'm not saying that that we don't have those examples, but based on this data, what my practice has come to shift to is that there is data that other medications are more likely to work better and more likely to work, period, than trihexyphenidyl. So I no longer use it as a first-line medication. And this is a shift in practice for me, and it may be a shift in practice for many of you. And I'm happy to talk about that more in the Q&A period. Levodopa. So the dogma for me was that I came up with during training is that everybody in whom you recognize dystonia deserves a levodopa trial, that they're owed a levodopa trial. You don't want to be that person that misses dopa responsive dystonia. They're owed a levodopa trial. So we often, very commonly, would put children through a 1-month levodopa trial up to 10 milligrams per kilogram per day to make sure that their dystonia was not responsive. What many of us know is that in people with cerebral palsy that do not fit a dystonia responsive dystonia or a dopa responsive dystonia phenotype, that neurotransmitter dystonia, neurotransmitter disorder phenotype, which is a progressive dystonia. Classically, the classic phenotype is onset in childhood, or even if it's onset in infancy, you'll see that the dystonia progresses, is associated with other stigmata like oculogyric crises, and this, in some cases, a ptosis-like phenomenon. If they don't have that picture, and if you don't have that suspicion for that diagnosis, if you think they truly have cerebral palsy, a non-progressive phenotype, the chances that Sinemet will work are low. And for many of our kids with gastrointestinal associated symptoms, which many of our kids with CP do have, Sinemet can cause harm. There are a lot of GI associated side effects for Sinemet. So I don't use Sinemet as first line either anymore. I don't, as a rule, do a levodopa trial. And these have been changes to my practice in recent years. Again, I'm happy to discuss. I think this is a newer and controversial approach, I think. The last things to think about are next line treatments after pharmacologic agents. Botulinum toxin has shown improvement for focal dystonias, and then intrathecal baclofen and deep brain stimulation, which I'll talk about on the next slides. We have started to think about surgical treatments for dystonia in a similar way to how we approach surgical treatments for epilepsy, in the sense that if a few medications fail you, if you fail, or if these medications fail you for treatment of your dystonia, and you're hitting the second or third medication that you're trying for someone's dystonia, to think about a surgical treatment for someone's functionally impairing dystonia. And that's not how we had always perceived it. We had kept sort of kicking the surgical can down the road for our kids with dystonia. But for functionally limiting dystonia, it's worth considering if the pharmacologic treatments you're using are not effective, and this dystonia is truly functionally limiting for this person. We have historically only thought about this for severe generalized dystonia, but I would encourage you to offer it to your families if their dystonia is otherwise functionally limiting. And the options I'm talking about are ITB, intrathecal baclofen, and deep brain stimulation. ITB is not, this is not the classic ITB we think of for spasticity with the lumbar spine catheter placement. This is high C-spine catheter placement. Some people have even talked about intraventricular baclofen for people with severe dystonia. And the concept is that this baclofen isn't necessarily working at the spinal level, but is diffusing through the foramen magnum intracranially and allowing for higher dose baclofen to penetrate into the brain. And there have been studies that have shown that this has been very helpful for generalized dystonia. The availability here in the US is limited center to center. So there isn't a lot of consistent availability here. And I'd be eager to hear what the practice is for you all with using high C-spine intrathecal baclofen for the kids that you see or the people you see with dystonia. All of these studies, importantly, also showed improvement in pain and comfort, which is an important metric that we all should be aware of when we're talking about dystonia. Over 50% of dystonia say, 50% of people with dystonia say that their dystonia is painful. So thinking about pain as a metric is really important. Deep brain stimulation. Here in this country, DBS for dystonia is only FDA approved for implantation in the globus pallidus pars interna, which is a specific basal ganglia nucleus. That means that when we're looking for candidates, we need to make sure that that GPI, that part of the brain, is relatively uninjured. When we look across studies, and these are studies that have been conducted internationally, mainly in Europe and the US, a group meta-analysis suggests that DBS does improve dystonia in people with CP. There has been a general disappointment, I think, in the effect of DBS for dystonia and CP, in part because we see the outcomes for DBS for certain genetic dystonias like DYT1 or TOR1A associated dystonia to be practically curative. So when you see that robust response to DBS in a certain population of children with dystonia, and then you don't see as clean or as clear of a response in people with CP, it's easy to think that it hasn't worked. But I will say that not only do the ratings for dystonia improve on these dystonia scales, even though they don't go down to 0, but families also report a lot of benefit from DBS. And those reports of benefit also include pain. So there's a reduction in use of analgesics, and there's a reduction in reports of severe pain. And that is data again from Jean-Pierre Lin and colleagues. Paredes is the first author on that paper. So thinking about pain, thinking about quality of life, thinking about dystonia reduction, and all of those things together can be important. And not thinking about surgical treatment as something that you only do for your kids with absolutely severe dystonia. Thinking about, is this dystonia functionally limiting for this person? And seeing if they have an understanding of what these surgical treatments might provide them, and seeing if they still, offering it as an option can be valuable. So letting people know about these options can be valuable. So as I said, the AAC-PDM care pathway is still in process, and we'll use that as kind of a standard bearer for treatment approach for people with CP in the US. Until that revision is up, I'm just going to tell you what I do based on this data and based on also my clinical practice. So please take this, please take that caveat in mind as I go over this. I tend to tailor my first line treatments are pharmacologic, and I will tailor them based on coexisting concerns. And very much like we would approach epilepsy, when you pick your first line medication for epilepsy, if someone has migraines and seizures, you might think about topiramate. And we do something very similar when thinking about pharmacologic treatments for a dystonia. If someone says that pain, that their dystonia is very painful, or if they have a sensory component to their dystonia, meaning that they have poor proprioception in that limb, or they have they have difficulty recognizing where that limb is in space. We see this very often in our kids with hemiplegic CP after stroke with the dystonic arm. Recognizing where that arm is in space can be difficult. For those kids, I have personally found in my practice that gabapentin can be helpful for that dystonia. And I will start with that first line. I will titrate it high, at least up to 18 milligrams per kilogram per day, if not higher. For our kids that have sleep limitations, if you're not sleeping well, everything is going to be worse, including your dystonia. And people that have sleep issues, autonomic instability. So we think of that sometimes in its most severe context, like autonomic storming. But sometimes autonomic stability can be, I get cold really easily. I get hot really easily. I'm sweaty for no reason. My arms and legs are red for no reason. And it's that sort of milder end of autonomic stability that can be worth eliciting on history when you talk to these families. If there are signs of that, or with signs of significant mood lability during the day, I will do clonidine first line. And again, I will titrate this very high. So I really titrate to, honestly, to unless we hit hemodynamic instability. So if someone is able to walk without being, if someone is an independent ambulator and they can walk without dizziness, and their blood pressures and their heart rate are holding tight, and their dystonia is at least partially responsive to clonidine, I will keep pushing it up. And again, this is my personal practice. So again, take this with a grain of salt. If there's significant comorbid or coexisting spasticity, which many of our kids have, I will do baclofen. When I talk about gabapentin and clonidine, these are for our kids who have spasticity in all four limbs. They're often already on baclofen by the time I'm starting gabapentin and clonidine. They're already on baclofen for their spasticity and have maxed out on that. But if they have not, then I will try to optimize baclofen first, particularly if spasticity is a significant functionally limiting component for them. For kids with seizures, I will try clobazam. Clobazam is a non-sedating benzodiazepine that we commonly use for treatment of epilepsy. So I will use that to double cover for seizures and for tone. And I am very wary of Botox for dystonia. I will only use Botox for focal dystonia if that limb is also significantly spastic, and also if that spasticity is causing significant functional limitation in that limb. And I say that because if for many of our kids with upper extremity dystonia, that limb does not have a significant component of spasticity when at rest. It's just that the dystonia is very active when that child tries to move. And because of that, that limb is also very weak and oftentimes even hypotonic at rest. So doing Botox in that limb can lose a lot of the strength that that child has in a weak limb at baseline. So I'm very, very wary of Botox as a treatment for focal dystonia. But for kids that have a lot of spasticity in that same limb, I will do Botox to assist with optimizing range of motion, seeing if they can tolerate their hand bracing better, and particularly for children that need to use that limb to use communication devices, or for kids that need it to reach out and grab something to feed themselves. It's for those specific goal-based tasks, and only if there's a lot of spasticity in that limb that I will consider Botox for dystonia. So that is my personal preference. Also happy to discuss that. And then second line, if we've tried a few of these medications, this functionally limiting dystonia is persistent, I will consider a DBS if they have a hyperkinetic. So if they have a lot of good strength and have a highly mobile form of dystonia. In our center, we don't do C-spine intrathecal baclofen for dystonia. So I don't personally have a lot of experience with it. But I know that other centers will consider high C-spine ITB, particularly for kids with severe generalized dystonia. And it's something that I think should be discussed more with families with functionally limiting dystonia. I talked about first and second line. I call this a little bit tongue-in-cheek zero line because I think one of the most effective treatments for dystonia can be addressing the triggers. I talk a lot about a young man that I see for his dystonia, whose dystonia acts up predominantly when he goes to restaurants, so when he's out in public, and it's an anxiety trigger for his dystonia. I think we should be wary of that. So when is your dystonia, or we should be aware of that? When is your dystonia most functionally limiting for you? If it's an anxiety trigger, consider treating the anxiety. And often it's that anxiety treatment that is the best treatment for their dystonia. It's not the direct tone treatment. It's not a benzodiazepine. It's not baclofen. It's if your dystonia acts up when you're anxious, treat the anxiety. And so thinking about those triggers can be really valuable, particularly for kids that have where we have difficulty understanding them, or they have yet to get the communication devices they need to help them communicate optimally. For people that we have trouble understanding, pain and occult causes of pain can be a cause of dystonia. So looking for this can be valuable. In someone who looks to be in pain, their family may say they seem to be in more pain, And even if they can't communicate that with you, looking for those causes of pain can be maybe even the initial thing you need to do if someone is starting to ramp up with the degree of dystonia they have. So we will think about skeletal surveys. We will think about switching feeds around, thinking about the timing of when that dystonia happens, look for occult infections. All of these things can be valuable and in some cases can be life-saving, in addition to helping with their dystonia. And then lastly, and perhaps most importantly, sleep. Every single visit, I ask my kids about their sleep. I ask families how the parents are sleeping and how the kids are sleeping. If people are not sleeping, dystonia is going to be a problem. Everything's going to be a problem. They can't get to their physical therapy. They won't be able to engage in physical therapy. So, and poor sleep will beget dystonia. The stress from poor sleep will worsen dystonia. So I am vigilant about optimizing sleep in our kids with CP. As a dystonia treatment and also as a quality of life issue, but really as a dystonia treatment. I think these things need to be optimized before we start talking about tone meds as well. So this is just in summary. So I talked about the diagnosis in at least large part because I think it's so important to diagnose in order to manage. Make sure that you're not just looking in the arms, that you're looking in the legs, that you look for variable adduction of the feet and the legs, and that you're looking for overflow activation. So in the exam room, if someone is doing arm maneuvers, or if you're stretching someone's leg, look at the other parts of the body while you're doing that. That can be some of your best signs of dystonia. Management. So addressing triggers and treating based on coexisting concerns, and letting families know about their options and really thinking about, is this dystonia functionally limiting? Is this surgical treatment an option? And being honest about what the possible benefits of that surgical treatment are. We cannot expect families to think, or we cannot send families to surgery telling them that these surgeries will make their dystonia go away. But we can tell them that it might make it better. It might reduce their pain associated with the dystonia. And if those are goals that are important to them, it's important to let them know about these options. And then when thinking about dystonia in cerebral palsy in general, please stay vigilant. The first visit is not enough. Assess for dystonia at every visit, every time you see a child, during every maneuver. It is variable, it is elusive, it is a sneaky diagnosis to make. So look for it everywhere and look for it every single time. And focus on function. Just because someone comes to you with a spastic CP diagnosis doesn't mean that dystonia is not their main functional problem. So think about what is functionally important to that person and address that when focusing on management. These are my multiple acknowledgements. I have my trainees bolded, who I'm very proud of and who've contributed a lot to our work in the lab. And my contact information, email, Twitter, and our website is below. So I look forward to hearing more from you, and thank you for the honor of speaking today.
Thank you.
Thank you, Dr. Bhooma.
Thank you for excellent lecture, Dr. Bhooma.
Yeah.
Excellent,
Thank you so
excellent.
much.
Dr. Shilpa will
So,
take over.
yeah. So Dr. Bhooma, you have many questions from the audience. That means it was an interesting talk and everybody is interested in chatting with you. So I'm going to facilitate that chat by asking questions. But prior to that, I have to ask you a few questions, if you permit.
Of course, yes.
So
Yeah.
my first question, that it was very nice screening tool what you told about those two signs which you ask parents, whether there is movement in one limb which causes a movement in the another limb. So I know that these are very good questions. So how do we differentiate them from the mirror movements which we see, which are not associated with dystonia? So can you clarify them clarify it for the audience?
Yes. So that is difficult to do with that question. And with that question, you are likely to get people who say yes for mirror movements. So I want to be clear on that. What you will not have them also say yes to is the tactile stimulation question. So when someone handles one part of your body, a different part of your body moves. Yeah. And so yes to both of those questions together, that are most specific to dystonia. Yes, to the first question is sensitive for dystonia, but it is not specific because it will catch a lot of the mirror movements that you're talking about. Even on exam, yeah, for particularly as early in your career, early in my career, when I was looking at dystonic movements, it can be difficult to differentiate. The most common places we see mirror movements are in the hands. And this task that I keep harping on is a task that experts commonly cite as being very good for eliciting, differentiating between dystonia and mirror movements. When you have a repetitive task, a mirror movement should follow that task in rhythm and in speed. So if you were to have dystonia, dystonia would not move time locked to the contralateral hand. So a dystonic position of this hand, a dystonic overflow may look like the hand splaying or the hand stiffening or the wrist flexing, but it wouldn't look like this time locked, it wouldn't mirror it exactly. And that mirroring can be very subtle, I agree, but looking for that sort of time locking is important in differentiating between the mirror movement and dystonia. Something that I didn't mention earlier is that mirror movements can actually be a developmentally normal movement. We see it sometimes in kids who are typically developing. So it's important to not call that a pathologic dystonia. And it's that time locking that I use to differentiate.
Yeah. Yeah, it was nice explanation. So now I'll ask questions which are asked by the audience.
Yes.
So Dr. Aarti is asking that which kind of pathological gait patterns we can see in dystonia or dyskinetic CP.
Yes. So what we found in terms of gait is that, especially in gait where you're watching someone walk towards the camera, the movements we see are the foot coming in or the leg crossing in that was not present when they were standing, so before they started walking, and is not clearly present when they're seated or at rest. So you'll see during the course of gait that the foot may come in and it may intermittently come in. It may not come in and stay there, which is, I think, what we might expect or what may occur with more severe dystonia. But cycle to cycle, the foot may come in and then go back at the next cycle. So looking for that intermittent foot turning in or leg crossing in cycle to cycle is what we tend to see for gait dystonia and cerebral palsy. This is not true for all etiologies of dystonia, but for cerebral palsy, that's the typical gait abnormality that the experts have picked up on and that we're trying to quantify.
Next, in a neonatal brain hypoxic or bilirubin.
Oh, I'm sorry, I'm not hearing you.
How early can we pick up dystonia?
Yeah.
In case of neonatal brain injury.
So that's an excellent question. The hypertonia assessment tool that I showed you, and I'm seeing a question in the chat about where to obtain that. So I'll look up that link and put it in the chat as well. The hypertonia assessment tool is validated at age 3 and up. And there's a reason for that. And that's because a lot of the movements that babies make can appear dystonic and can be a part of what some people call like a developmental dystonia. So there are some movements that babies do that can look somewhat dystonic, that can be developmentally appropriate. The earliest that we have validated tools to pick up on dystonia is at age 3. I think the earliest that you are able to pick up on dystonia in a child is when they start being able to make voluntary movements. So to me, that's around 6 to 7 months of age when you would expect someone developmentally to attempt to reach for an object. It's at that sort of age that I think it's easiest to start picking up on it. It's hard to know if it's because of that or not, that we see that after neonatal brain injury, there's typically a period of months of delay before you see dystonia emerge. Typically, a baby after neonatal brain injury tends to be hypotonic if they're eventually going to have a significant dystonic phenotype. They tend to be very floppy, have a lot of slip through, have a poor movement repertoire, very few movements early in life. Those typical fidgety sort of hand movements we see with the Prechtel general movements assessment, we don't see. And then around 6 months of age, you'll start seeing dystonic positioning when there are attempts to reach for things. And that can manifest as the same sorts of positions that I showed you earlier in the talk, the hand twisting, the finger splaying, the wrist flexion, the foot turning in. Scissoring is a really big one, difficulty with changing their diaper and opening their legs. But then when they're asleep, they sleep what we call frog-legged, with their legs completely abducted. Those sorts of positions you start seeing around that time.
So what about retrocollis and posturing, which we see early or very early pickup of striate toe? Are those early markers to find out that this baby could have dystonia later on? And sometimes what happens is whenever you have a certain position, that child is irritable or postures in that position very early in the life. So
Yeah.
it is important in terms of therapy point of view, like it becomes difficult for parents to carry those kids. So is it important to identify at means early and not up to 3 years? We mention about the.
Yes, it is very important to identify, and thank you for letting me clarify that. So even though that tool is only validated from 3 and up, we start seeing signs of dystonia in infancy, like I mentioned, and some of the irritability and associated stiffening that you see in the setting of that irritability can be a sign of that. I still think we start seeing those movements around, 4 to 6 months, 6 months typically. But identifying it at that time can be critical to starting therapies and starting treatments needed for that dystonia. I absolutely agree. So you start seeing it in infancy. These are the floppy babies at birth. And when these floppy babies start developing tone around 6 months of age, that's really, intervention should start then. We shouldn't wait until age 3. Thank you for letting me clarify that.
Yeah. So when a child with dystonia walks on an uneven terrain, dystonia increases. So would you change your classification from mild to moderate for that particular child? This is a question by Dr. Ghosh.
Yes, yeah, that's so no. I'll tell you a little bit about the GDRS, the Global Dystonia Rating Scale. So it is a complete, and that's the scale that was used in this study for mild, moderate, severe. There is no sort of guidance for how that scale should be used. It's a pure Likert scale without any sort of guidance for how that severity scale should be applied. For people that do tend to have dystonia worsening during more complex tasks like walking on uneven terrain, we would still say that's mild dystonia, because you have to have this, all things considered, even if you don't see that dystonia in even terrain, but then it comes out during uneven terrain, I would still classify that on the milder end of dystonia, because you have to have a provoking maneuver. But with that said, for that particular scale, there is no guidance on how that scale should be applied. It's just based on expert consensus, but that is my that's how I would rate that dystonia.
Yeah. Can you comment a little bit about oromotor dystonia?
Yes. So oromotor dystonia is, we see it in people with CP. It tends to be in people that have generalized dystonia. The triggers for oromotor dystonia can be attempts to speak, and it can really be limiting with feeding. It's tough. It's very difficult to treat. Because oromotor dystonia tends to be one of those truly triggered dystonias, meaning the attempts to speak is when I've seen it very commonly. Often anxiolytic medications, particularly in older children, can be helpful for oromotor dystonia. I have personally not seen significant benefit with clonidine for oromotor dystonia. I have seen some benefit with gabapentin, but in the older children with attempts to speak and associated oromotor dystonia, I've seen the greatest benefit with anxiolytic medications.
Okay, there is a question from Ramya. Can you please explain how dystonia is considered in surgical procedures once again?
How it's considered in surgical procedures, sure. So a couple of different considerations. Dystonia early in life, if you're thinking about doing a selective dorsal rhizotomy, which I did not talk about very much in this talk because it's a treatment for spasticity, a selective dorsal rhizotomy, where you're cutting the dorsal nerve roots to the lower legs to decrease to some degree the sensory drive and the hyperreflexic arc to decrease spasticity in the legs. That is the theory. There is a theory that it can worsen, it may unmask dystonia in the legs that may have otherwise been masked by significant spasticity. Or at the very least, if dystonia is the main functional component limiting your gait, then an SDR is not going to help that dystonia. So diagnosing dystonia early in life can be an important prognostic factor for whether an SDR in an ambulatory child will be effective. So that's surgical consideration 1. Surgical consideration 2, and this is now in parts, is after you have established that you have dystonia, and there are certain medications that you've tried that do not seem to be working well for your dystonia, and you still have very functionally limiting dystonia that you would personally find benefit in reducing at all. So some of the metrics are something like 20 to 30% reduction on these scales. It's hard to know what that means for you functionally. But if you have, let's say, hyperkinetic dystonia, where every time you try to move, one arm moves out of your control, you really want to limit that dystonia for functional purposes, then thinking about deep brain stimulation or intrathecal baclofen can be useful. Deep brain stimulation in kids with this hyperkinetic dystonia pattern tends to be more effective in our experience than kids who are akinetic, meaning that they move very little and any movement they have leads to a dystonic positioning. Hyperkinetic is people are able to engage in voluntary movements, people are able to elicit voluntary movements easily, but those voluntary movements tend to have a lot of dystonia associated with them. So in that group of people, DBS seems to work better than in the akinetic group of people. For those people, DBS can be considered. ITB, C-spine ITB, in the people that I've seen it in, has predominantly been in people with severe generalized dystonia at the high C-spine level. And I don't know much, honestly, about systematically offering C-spine ITB, C-spine intrathecal baclofen for people who are, let's say, a GMFCS2 with significant functionally limiting upper extremity dystonia. There is a limited amount of data there, but it is a surgical option that is available and I think should be discussed with families so that they can know about the option and decide if it's one for them. So then 3 surgical, so to summarize, there's the SDR, and that's not, you should get an SDR if you have dystonia, but you should know you have dystonia before you think about an SDR, so that's 1. And then there's DBS and intrathecal baclofen, and then deciding between that is typically after you have not had good response with oral medications or injectables.
Just one more surgical procedure. What is the role of pallidotomy in severely generalized dystonia?
Okay, yes. You know, so I think it's possible. I don't think there's any reason that we cannot do a pallidotomy. We don't often do pallidotomies in the US. We often rely on the DBS procedure, but we know that DBS evolved as a condition, as a technique based on pallidotomy, thalamotomy, and lesions in the subthalamic nucleus, and this was in Parkinson's disease. So we know that that body of data is where DBS evolved from. I think if you have a child with severe generalized dystonia that is hyperkinetic, meaning that they have a lot of, they're able to elicit voluntary movement, and they're constantly, whenever they try to elicit that voluntary movement, they have this dystonia, I think there can be a role for pallidotomy. But I personally do not have experience with pallidotomy, but I think it conceptually could make sense.
Yeah, so in India, DBS is not yet very popular because of the cost and ongoing monitoring process procedures. Like you need to do the modeling and then monitoring of those
Yes.
DBA stimulation. So that is not very popular in India, but we have many patients who have very severe dystonia. So, I mean, pallidotomy, that's why we were considering that whether there are good results in cerebral palsy, because cerebral palsy per se is not only a disorder of globus pallidus and other things, but there is other brain involvement which also is causing a lot of other movement disorders and posture issues in these kids.
Yeah, and then that's a, oh, sorry.
No, no, no. Please, please, please.
Oh, no, so I just want to highlight that's a really valuable point, because the brain MRIs of our kids are not, normal, so to speak. There's a lot of other injury patterns to take into account. If you have an intact GPI, and this is for DBS or pallidotomy, because really conceptually we're talking about something very similar. It's important to look at what other sort of injury patterns this child has. For example, and the selection for DBS targeting is nuanced in that way. So if you have a lot of posterior limb of the internal capsule injury, which is suggestive that you are going to have a lot of limitation with your leg movements from upper motor neuron injury. If the functional improvement that person wants to achieve is in their legs, the chances you'll get that with DBS or with pallidotomy are probably low, because their plics, their posterior limbs of the internal capsule are already severely injured. So it's important to correlate, to look at those injury patterns, particularly the white matter injury patterns, and associate that with the expected functional improvement the family is expecting to achieve. I think if you have severe generalized dystonia in a person who's a GMFCS 4 or 5, and it's just kind of global reduction of dystonia that you're looking for, I think a DBS could be effective, and I think a pallidotomy could be effective in those situations. But if you're looking for, I want to reduce, I'm still able to weight bear, I'm using a walker, but I have a lot of dystonia in my legs, and you have a lot of posterior limb of the internal capsule injury, I'd be careful there about promising anything with DBS or pallidotomy. So it's that nuance is a whole other topic, I guess.
Dr.
So you
Shilpa,
have
shall
another-
we? There are many questions are there. We will share those questions with Dr. Bhooma,
Okay.
so that we can correspond it. There is one question from Dr. Purohit that you can take up, or he can speak, or we'll please summarize the session and.
I can't see Dr. Purohit's question.
Tell you the
Oh.
question. I have
How-
a question. I'll tell
How
you
to
some-
treat? How to
How to
treat
treat
segmental dystonia?
say in
in,
one
say,
upper limb in a teenager.
Teacher.
Where
I'm
is
sorry,
it?
what?
I didn't see.
I'll repeat it. How to treat segmental dystonia in, say, one upper limb in a teenager.
Yeah.
Arre baap.
Okay. So if you have segmental dystonia, so if you have pure upper limb dystonia in a teenager, and some of this is based on etiology. So is this someone who someone who'd had a stroke, and is that the etiology of their cerebral palsy, or you think they have a spinal lesion and have associated upper extremity limitations there? I guess sorry, go ahead.
No, please go ahead. I think Purohit sir, if you're there, please answer her, sir. CP only. He says CP only.
Okay, so if you have upper, and this is very common actually, and this is the hardest dystonia to treat, to be honest. So it's a very good question. So in our kids with hemiplegic CP who have had, particularly our kids with stroke, who often their leg spasticity, they'll have leg spasticity, and that's something that is honestly with bracing, orthotics, sometimes medication, but really with bracing and orthotics, you can probably handle that really well. It's that upper extremity dystonia in a limb that's often not that additionally spastic, that's a killer. It's very difficult to treat that dystonia. Often in those kids, that upper limb is also a limb that has proprioceptive deficits. So you'll see sensory motor combined deficits in that limb. If you ask the family, do you feel like your child knows where that limb is in space? They'll say no. So we focus a lot on physical therapy and occupational therapy for that limb, and we'll do sensory kind of guidance focused therapies. So wearing a compression sleeve on that limb, again, and I will caveat, none of this is evidence-based. This is my personal practice. So I will focus on sensory cueing for that limb with compression sleeves, with physical therapy and occupational therapy. If they notice a sensory deficit in that limb themselves, sometimes I will try gabapentin, but it has helped, but I'm not sure how, it's not as dramatic of a response as I see with other types of dystonia. I do not Botox those limbs because often they're very weak in between the episodes of dystonia. And so I focus predominantly on, oh, and I see the follow-up, what about a selective neurotomy, a selective motor fasciculotomy? It can be tried. I worry a bit about the weakness component of it again. So it depends on what the functional outcome is for that family. If that child wants to retain a certain amount of strength in that limb, I worry a lot about, and this is true for ventral, so-called ventral rhizotomies as well, that have been proposed as treatments for dystonia. So that sort of the motor lesioning, I worry about the associated weakness. But if mainly what the family's looking for is cessation of the movement, and they are not looking for sustained use of that hand, then I think a neurotomy is something, a motor lesion is something that can definitely be considered. It's just that often in the kids that I see, they want to retain that strength. So that's the balance I'm trying to strike.
Thank you so much. Thank you
Yeah.
so
Yes.
much. So I have to do the honors of vote of thanks. So I thank Dr. Bhooma for an excellent presentation. I thank Dr. Shilpa Kulkarni also for a great moderation. Thank you so much. And I thank all the people. We had almost 300 people on Zoom, and we had a lot of people watching on Facebook. Lovely question and answer. So on behalf of Indian Academy of Cerebral Palsy, we thank each and everyone for being here. A great weekend and a great evening. Thank you one and all. Thank you so much.
Romba
Thank
nandri.
you.
Oh,
Thank you very much.
Thank you.
Excellent
Thank
lecture.
you.
Excellent lecture. And in my WhatsApp, there are appreciation messages are pouring in. I will share it with you.
Good. I'm
They
so
are
glad.
very,
Thank you.
they're very,
Good.
very happy, and they learned a lot, and we'll have a collaboration with your organization in future for research and any activity in India. And if you
Of
could
course, I would be
your-
honored.
support our activities.
Absolutely. Absolutely. Yes. I'll tell my amma appa kitta solran. They'll be so happy. Romba romba nandri. Vanakkam, sir. Thank you so much.
Thank you very much.
Thank
God bless you.
Thank you, everybody.
Thank you.
Thank
I
you.
thank Dr. Jasmeet Arora for providing me the huge platform, because our ISCP platform can accommodate only 100 delegates, but she has very tight till morning till now. She's busy with her work, and in spite of that, she extended her support and offered us all the technical facilities. Thank you, Dr. Jasmeet.
Thank you, everybody.
Thank you very much. Thank you. Thank you.
I'm just ending the meeting now.
Okay.
Bye-bye.
Okay, thank you. Bye-bye.
Thanks
Thank you.
all. Bye.
Thank you, Madam.